So everyone, want to thank you for joining us for, I'm just going to say it, this shit lasts forever, dealing with long-term side effects. You can interact and ask questions via the chat and the Q&A. So if you are chatting, make sure that you do it so everyone, like choose everyone instead of host and panelists. Please remember that all of our sessions are meant to be informational. And any treatment decisions should be made with your healthcare team. So, Dr. Stubblefield, take it away.
Let me unmute. Hi, everybody. Welcome and thank you. I'm joined today by Kira Savage, who's a physical therapist on the inpatient side at Kessler Inpatient for Rehab, and just been an absolute rock star as we've developed our program there. And then Elena Newell, who's also just a rock star. She's our director of education and has just been fabulous. Now, my first question is, are we sharing our own slides or are they putting up the slides for us? Okay, awesome. So first of all, thank again everybody for joining us on this Saturday, and I saw in the chat people coming from just all over the country. So what we're wanting to do here is talk about some of the long-term and the late complications of cancer and really the treatment of cancer. You should understand we chose breast cancer. So we chose Hodgkin's lymphoma, not because we expect all of you to have them, although breast cancer certainly is the most common, but because they're very illustrative of some of the issues that you are likely to experience, sometimes in a much more pronounced manner than some of you may have. And it'll give us an opportunity to really just talk about some of the treatments. Next slide. All right, so first of all, what is cancer rehab? Well, it's very much a process. The whole idea of cancer rehab is that we help cancer survivors obtain and, very importantly, maintain the maximal possible physical, social, psychological, and vocational functioning, very importantly, within the limits created by the cancer and, of course, the treatment of cancer. And in some cases, the treatment of cancer, even if your cancer is cured, as this group I'm sure knows, can be very devastating, can be very function limiting, can really change your life. Next slide. So why do we need cancer rehab? And this is one of my cancer survivors who has a low-grade brain tumor who enjoys playing tennis. Well, the idea is to get back to doing the things you love to do. Next slide. So one of the nice things about oncology, and these numbers change year to year, is that we've actually gotten much better at treating the cancers. Even stuff that traditionally was considered just a quick death sentence, like melanoma, we've actually gotten very good control rates, certainly not cures yet, but for things like breast cancer, somebody with an early stage breast cancer really can expect to live a normal life and not die as a result of the breast cancer. And even patients who have fairly extensive breast cancer actually can do very well because our treatments simply keep getting better and better. Next slide. So there's, and again, these numbers just keep going up. There's at least 17 million cancer survivors in the United States as of the year 2020. That number is going to increase to about 22 million by the year 2030. And we're looking at less than 300,000 spinal cord injuries and about 600,000 deaths from cancer. So we look at something devastating like spinal cord injury, we look at our cancer rates, we see the spinal cord injury is about 50-1, but we spend a lot of time rehabilitating cancer survivors, or forgive me, the spinal cord survivors, and I don't know that we spend enough energy, knowledge to really rehabilitate cancer survivors on kind of a global scale. Again, the three of us, that's what we do for a living, but in other cases, not so much. Next slide. All right, so poll time. So which common issues have you or your family members experienced during the cancer journeys? Well, you know what? I'm seeing a lot of people put it in the chat, and I'm going to put the chat over here. So I'm seeing fatigue, joint pain, nausea, emotional issues, absolutely. So we're just going to go old school, fatigue. Fatigue is far and away the most common. Right, memory issues, tinnitus, depression, PTSD, which we probably should put more on our list. Wow, yeah, so you guys are great, and you're hitting a lot of the things that we're hoping we're going to be able to talk about. Awesome. Next slide, please. Keep putting them in there. We really kind of like to know. All right. So as I said, I kind of use the spinal cord injury as a comparator to cancer. But for patients who have cancer, even though you guys are lighting up our chat box with issues related to cancer, most people, maybe half of it at least, need cancer rehabilitation, but 1% to 2% across the country actually have access to or get cancer rehabilitation. It's been an ongoing issue my entire career. We actively work to change it. That's part of this talk, is to let you know what we can do, talk a little bit about how to access it, and talk about what your expectations for cancer rehabilitation should be. Next slide. All right. So what are the causes of impairments? I said before, it's cancer, but very importantly, the treatment of cancer. So the cancer itself certainly can cause major issues, up to and including death in cancer survivors. But the therapy is really the source of the vast majority of evil I see in my clinic, largely because there's so many more survivors, fortunately, than there are people who are going to be dying of their cancer. So the systemic treatment, so chemotherapy, we know can cause neuropathy and cognitive issues and heart issues. But even those biologic therapies, like the aromatase inhibitors we use in breast cancer, they're like fibromyalgia in a pill. They cause all sorts of pain issues as a result of them. And some of these newer monoclonal antibody targeted therapies are causing issues that are really new and novel for us. The more we use them, the more we're seeing the patients will have issues with those. Radiation, one of my personal areas of expertise. I get probably more radiation-late effect patients than any other kind. This is the gift that keeps on giving. We'll talk about this quite a bit in our second talk. Surgery. We think of things as being, oh, you're going to have surgery and then you'll heal from it, which we'd like to think so. But things like breast surgery can leave, really long-lasting, significant pain, range of motion, swelling issues. Patients who are cured of their cancer from stem cell transplant or from the new CAR T therapies can have all sorts of issues. And then, of course, everybody who comes to the cancer world comes with their own sort of baggage in terms of their arthritis and their diabetes and their thyroid disease and their pre-existing anxiety or depression. And so all of those pre-existing issues just get worse potentially during the cancer treatment. Next slide. All right. So what are some of the common issues? Far and away, the most common issue experienced by most cancer survivors, it's fatigue. It's actually the thing that is complained more about even than pain. Pain's probably number 2. But weakness, deconditioning, loss of ability to use your muscles, inability to participate in recreation and family obligations, numbness, tingling, nerve issues that can also be painful, gait and balance issues with falls, cognitive issues often called chemo brain. PTSD didn't make the list, but absolutely, somebody put it in the chat, and that's right. Joint aches, soft tissue changes, trouble doing your regular activities of daily living, swelling, specifically lymphedema, and all sorts of pelvic health issues. Painful sex, right, can happen to patients as a result of this, even if it wasn't that region that was directly affected by the cancer. And this list can really go on and on. Next slide. All right, so poll time. Which of the following providers have you seen through your cancer journey? And by that we mean, we're going to assume that you've seen your medical oncologist, your surgical oncologist, your radiation oncologist. Have you seen a PT, a physical therapist, an occupational therapist, a speech-language pathologist, a cancer rehab doctor like me, an orthopedic surgeon, a neurologist? I'm seeing acupuncture, none of those. PT and a counselor. Physical therapist, good. And if you put in none, we appreciate seeing that too, because I think that's part of the thing here, is to educate you. Seeing a lot of orthopedic, chiropractors, yoga, chiro again. All right, rheumatologist. Okay, terrific. You guys, this is a very, very involved group. I love it. Thank you. I wish I could see you guys. That's the only problem with doing talks like this. All right. So can we go to our next slide, please? All right, so on the cancer rehab side, the truth is everybody is involved in cancer rehabilitation. I'm a cancer rehab physician. I'm kind of a rare entity. There's only a handful of us in the country. I'm a specialist in diagnosis diagnosing and treating all of these issues that result from cancer and the treatment of cancer. But there's physical therapists, and you can have a regular physical therapist, but we've been creating a whole army of cancer rehab specific physical therapists, also occupational therapists, cancer rehab specific speech language pathologists. Other members of the team are neuropsychology, lymphedema therapists, pelvic floor therapists, et cetera, et cetera. And for the vast majority of you out there giving me one or two answers, although Sharon here put in a ton of people, and I hope they've helped you, the vast majority of you, your issues can't be solved or optimized by one person. It usually takes a village to really get you the best outcome. Next slide. All right. Those are, when I'm not playing doctor, I'm a wildlife photographer, so those are red like kitty wakes for anybody who cares. Breast cancer, we're going to talk about. Next slide. All right. So this is just one typical treatment of breast cancer. Your experience with breast cancer may have changed from this. So we talk about patients being diagnosed, then they often go to surgery, but sometimes the chemo happens before the surgery. Then they go to chemotherapy, then they go to radiation. At some point during this, they have been treated, they have been, may have gotten a breast reconstruction or other things. And then once they're kind of done with that primary treatment, you're into survivorship mode. You may stay on an aromatase inhibitor or tamoxifen and continue through it. The whole point of this little graph here, and you see green is kind of like, okay, I'm at my baseline, is red is where all of these impairments from these treatments start sneaking up on you, right? So the pain that you might have post-surgery, the neuropathy, cognitive impairments from the chemotherapy, the cording that you get, the lymphedema that you get, and then when you get radiation, the fibrosis, all of these things sort of sneak up on you in the survivorship, and we'd like to think they get better and you get back near your baseline, but oftentimes they don't, and you're left with these issues indefinitely. Next slide. So some of those issues are certainly body image concerns, lymphedema, heart issues, cognitive issues, depression, anxiety, PTSD. Fatigue is the big one. Bone issues. Patients get thinner bones as a result of these treatments and are at risk for fracture. Musculoskeletal health issues, nerve issues, infertility issues, sexual health issues, etc. The list goes on. Next slide. So the treatment options, as I said, are really surgery or systemic therapy, which can be, reversed depending on your cancer type and which protocol your oncologist is following, radiation, and then these targeted therapies, which, as I said, the aromatase inhibitors, for instance, are like fibromyalgia in a pill, and they can cause issues long-term that, are just really an awful sort of Sophie's choice of, I need to take this to reduce my cancer coming back risk, or I take it, but I have joint aches and carpal tunnel and feel like crud all the time. Next slide. All right, so we're just going to run through a case real quick, and finally I'm going to let my favorite thing happen, which is to hear from Karen and Elena to talk about sort of the therapy intervention. I've been stealing the show here, and I apologize, and I'm trying to go quickly because we want them to have enough time. So this is kind of a typical case for us. A 37-year-old woman, a stage 2A, not too big breast cancer, poorly differentiated ductal carcinoma, but triple negative receptor status, which means that we don't have the tools like those aromatase inhibitors to effectively treat it. She received neoadjuvant, meaning before surgery, ACT chemotherapy plus carboplatin. That's because she was triple negative. We give that extra agent. She did get significant neuropathy. She said, I think it was because she was young, but she was because she was using these stockings and gloves that were cooling her extremities. There's not great data for that, but okay. I'm glad she did it, and she did get bad neuropathy. She then, after her chemo, underwent a lumpectomy and an axillary lymph node dissection with positive nodes. At the time I wrote this, I didn't have how many were positive. And then she got pretty standard radiation to the breast and to the armpit. And then was on tamoxifen, even though she was triple negative. Sharp Eye would catch that just because she was very weakly and she was a young woman with a fairly high risk cancer. So she went on the tamoxifen anyway. Next slide. All right, so she was self-referred. She found me all of her own. For arm pain, and she said that she thought it was due to cording. We'll show you cording, and I'm sure Elena or Kira will be happy to talk about it, but it's literally like these ropes going down your armpit, or they can even go down your chest wall after breast surgery or radiation. She didn't have a ton of pain, none at rest, a little bit when she moved. But interestingly, she was actually a neuropsychologist, as I recall, so she was very in tune with her own sort of cognitive state, where she had some poor memory, some difficulty concentrating, and she said she got really irritable when she was around a bunch of multiple voices and things like that. Just her inability to focus and concentrate really got to her. Next slide. So on physical exam, she had a Metaport in place. She had her lumpectomy scar. I'm going to show you all of this in a minute. And she had her axillary lymph node dissection scar. There was no redness, no real warmth. She did have cording in the armpit, and she had some swelling really on the breast and the chest wall. And she really just kind of couldn't fully move her arm through a normal range of motion, which is also very typical. Next slide. So here you can see, if I showed you the full shot, you'd see this left breast is swollen compared to the right breast. You can see here's her lumpectomy scar. Here's the axillary dissection scar. She had a little drain in here, which is what that little scar is. That's the Metaport on the other side. And you can see how the skin is puckered, and you can just kind of see the little, like, you know, that is tenting more than it normally should with a little bit of cording, which is easier to feel than see on somebody. I don't know if you, oh, we can't see your pointer. Sorry, I'm using my mouse, but I'm using it on my computer because I'm not running the slideshow. So sorry about that. Next slide. All right, so her sensation was pretty normal, except in the left arm. She couldn't feel like in this region under her arm, which is pretty common because anytime you do an axillary dissection, the nerve in there, called the intercostal brachial nerve, it's pretty much always sacrificed. And it's not like the surgeon did something wrong, it's just in the way of the stuff they need to get to, and it gets taken out. Her strength was good and her reflexes were good. Next slide. All right, so my assessment of her, and again, this is a relatively typical patient, but she had multiple things. She had the axillary cording, she had lymphedema largely of the chest wall. She had some post-surgical pain. She had a little bit of restricted motion, a little adhesive capsulitis, like a little early frozen shoulder, we call that. That intercostal brachial nerve distribution, she couldn't feel there, but fortunately she didn't have pain, and she'd had some mild cognitive impairment from the treatment. Next slide. So what did I do? Again, I get to make all these fun diagnoses, but the truth is I'm pretty useless by myself. This is a team effort. I sent her to physical therapy, I sent her to occupational therapy, and I sent her to speech language pathology and neuropsych for the cognitive issues. So I get to shut up for a little bit now and turn you over to Kira and Elena to kind of talk about things.
So what does it look like for this, for Sarah to participate in therapy? So once Sarah comes to therapy, it's really a matter of the therapist looking at what impairments Sarah has and how are those impairments affecting her participation in things like her self-care tasks, her ability to work, her ability to participate in things within the community. So for someone like that who's having limited range of motion at her shoulder and kind of lacking some of that mobility and also pain, in addition to the cognitive function, there's a lot of different things that we would be able to do with this individual. So the first thing would be kind of improving her range of motion of her shoulder. So between things like soft tissue mobilization, scar massage is really, really valuable, especially early on, post-op. Also, you find in someone like that, especially after surgery and pretty comprehensive surgery, someone ends up kind of protecting that shoulder. So you're not actually using a lot of the muscles of the shoulder. And during surgery, even as minor as it might be in certain areas, they're still cutting into some muscles. So those muscles have a little bit of work to do, not just in the front where some of the surgery might be, but even in the back of your shoulder where you're not necessarily strengthening because you're not using that arm as much after surgery. So early movement and the ability to kind of range that shoulder and be able to kind of mobilize the joint is really, really valuable to support the long-term management of that arm. Also, reducing the impact of fatigue on function. She didn't have a significant amount of fatigue, but as we know, fatigue can kind of build up and it can wax and wane. So being able to kind of incorporate a good exercise routine into her daily pattern would be helpful to combat that fatigue. Also, in terms of any pain management, she may not have pain now, but just kind of preventative measures to support decreased pain in the future to improve her quality of life. And then the cognitive rehab side of things. So that might be including both OT and PT, finding ways to support improving cognitive function, but also compensate for any changes in cognitive function. So some strategies that we might provide her are things like writing things down or keeping a memory log or kind of restructuring her day depending on what her energy level is or what her fatigue might look like, so that she can participate in those things that might require a good amount of cognitive abilities earlier in the day when she has more energy, and maybe restructuring what she's doing with the rest of her day. So there's a lot of different techniques we can use for that. And then having this kind of overarching thought of a balance between restoration and improving her function, but also that compensation and preserving the energy she has and prioritizing kind of the tasks that she's able to do throughout the day so that she can be as independent if she wanted to be, or be able to engage in those things that are really meaningful to her. Next slide. So we've got another poll here. So write in, what type of cancer are you or your family member a survivor of? All right, definitely got some breast cancer in there. Ovarian cancer, lung cancer. A lot of breast cancer. All right, so we picked a good first case then, and we can talk a little bit more about that too. And now Dr. Subafield's going to go through a lymphoma case.
Okay, should we go to the next slide? All right, so that's a Brewster's warbler. It's a hybrid, very unusual, very rare. This is like an F2 back cross, which is even more rare. So, but it's a good segue for Hodgkin's lymphoma, because a lot of the disorders we see in there are to most physicians unusual. And the reason we're going to talk about Hodgkin is because it's really a microcosm. For me, I've been doing this a long time, Kira and Elena, long, but probably a little bit less. For me personally, I feel that my biggest, most challenging patients are Hodgkin's lymphoma, head and neck cancers, and gynecological cancers, probably followed by breast cancer, but it really just depends. So this is a good group to really go through the litany of issues that can occur with somebody. So next slide. All right, so just a little Hodgkin's history, because it's actually very interesting. It was diagnosed in 1832 for massive enlargements of the lymph nodes and spleen in some patients who obviously had no treatment at that time. Early 1900s, we realized that x-rays could actually shrink it. And in 1950, Vera Peters, which is unusual for a woman to be such a prominent physician in that era, published the first evidence that localized confined Hodgkin's could be cured by radiation therapy. It becomes the first advanced malignancy of any major organ that could be cured by chemotherapy. And then by the 1990s, we really start getting multimodal treatment of Hodgkin's. Next slide. So Hodgkin's is staged. It's kind of important. Stage 1 means it's localized. Stage 2 would be it's like in two spots, but on one side of the diaphragm. Stage 3 would be above and below the diaphragm. 4 means it's out in an organ. That's important because it dictates how our treatments will be for Hodgkin's. Next slide. So the treatment back really before the 1980s and 90s was what Vera Peters had come up with. It was radiation. It was high dose radiation given by techniques that we would find very primitive by today's standards. While they were potentially curative, they left a mark. They did a tremendous amount of damage to these patients. Next slide. And the field that we used, because it was involving all the lymph nodes, we weren't that good with our imaging. We would just basically, if you had it above the diaphragm, we would radiate everything from the neck, right? They'd lose the hair on the back of their neck down to the diaphragm. They'd shield the lungs because they turned into jello if you gave them too much radiation. That's not compatible with life. And we'd hope for the best. To find out if you had Hodgkin's lymphoma below the diaphragm, we literally had to open you up because we didn't have CAT scanners or MRIs to be able to see. You've got to go back to what medicine we had at the time. And if you had it below the diaphragm, depending on where it was, we would extend that radiation field to be mantle and say periaortic, or everything which we call total nodal. You see, if they did periaortic and the iliac and inguinal, it looks like an up-down Y, so we called it inverted Y. So these patients had very large radiation fields, which meant that a lot of tissue was in the way of harm from the radiation. Next slide. So what happens, radiation, so we're using radiation right now to have this talk, right? You're seeing me because photons are hitting me and then bouncing back and ending your life through the screen. And we know that light will be absorbed. So most of the radiation we give is photon-based radiation, basically light, just highly energetic, highly focused. So that radiation causes fibrosis of the tissues. We call this the gift that keeps on giving. Even though the radiation is out of your body, that tissue is still damaged. And this, I'm using Hodgkin's, but you can apply this to breast cancer and gynecologic cancers and any other cancer, head and neck cancer that you might have. So the problems that occur as a result of the radiation causing the tissue to get hard, we call radiation fibrosis syndrome, meaning all of those bad things that we see, the atrophy and the weakness. I'll show you some of those as we go through this. Next slide. All right, poll time. How far are you or your family member from initial diagnosis? This should be fun. What is SLP? Speech language pathology. Oh my goodness, we have quite a range. 3, 5, exactly 5. Happy anniversary. 7, okay, good. 15, wow. Nice. 10 years, congratulations, Boyd. All right, I love it. Next slide. Thank you guys for sharing this. All right, so our patient, and this one I loved because she was kind enough to give me photos, which I'm photographing my patients all the time, just like I'm photographing birds, but she gave me photographs from her treatment, which is why it's so fun it's just so illustrated. So 53-year-old woman, history of Hodgkin lymphoma back in 1991, right? So right on the cusp of us starting to do more multimodal therapy. She underwent biopsy followed by a staging laparotomy, meaning you have to open up your abdomen and look inside because we didn't have good CAT scanners then. They took out her spleen because, hey, we're there, we might as well take out the spleen. They took out her ovaries and kind of moved them to the side to get them out of the field of fire from the radiation. Then they gave her mantle radiation, so from all the neck down to the diaphragm, with 4,400 rads, which you have no context for that, but that's a pretty good amount of radiation for a Hodgkin's. It's usually more in the 36 range, so 44 is actually pretty high. And she doesn't have Hodgkin's now. So her cancer was cured by this, right, which was done back in 1991. Next slide. So here she is. And, you know, you can see these things dated back in January of 1992. You can see she went through the staging laparotomy. This is her being marked up. You see these little things for where they're going to put these little blocks right here to block the radiation, right? And they're going to try to shield her arm. So they're trying to get everything from here then to the diaphragm, and this looks like on the back. And again, you shield the lungs because the lungs don't respond well to radiation. But as you can see here, the lungs are still in the field. But you know what else doesn't respond to that kind of radiation? Everything else in the field, right? So even though this is curative, this is going to damage literally every tissue in that field, and that damage is going to get potentially progressively worse over time. Next slide. So she comes in with multiple nerve and muscle pain, like visceral organ issues from the Hodgkin's treatment. And one of the things, the term I kind of coined as I started seeing a lot of these patients, so you can blame me for this, and I'm the only one who can say it 3 times fast that I'm aware of, myeloradiculoplexoneuromyopathy, meaning it damaged her spinal cord, the little nerve roots coming out of her spinal cord, the plexus where they connect in your sort of shoulder girdle here, the nerves that come off of that, and then the muscles in the field. She had trouble lifting her head up. She had neck pain, she had migraines, and she had some problems with blood pressure because the little carotid baroreceptors, which are basically your little thermostats in your neck to regulate your blood pressure, had been fried. Next slide. And here she is when I saw her, right? So you see now all of this just terrible atrophy of all of this. I can only show you this one side. The shoulders are forward. She's like this. She's having trouble lifting her head up. Her heart probably isn't working well. Her lungs probably aren't working well. Sometimes the esophagus doesn't work well, et cetera, et cetera. You can just get so many issues in this. This is why this is sort of my paradigm for cancer rehabilitation. Next slide. So her primary were this dropped head, trouble lifting her head up, neck pain, which is cervicalgia, the migraines, which can also be directly related to this, the blood pressure issues called baroreflex, and then, of course, fatigue, just to name kind of the top ones that she complained of. Next slide. All right, so now I get to turn this back over to Kira and Alina.
So for Jackie, it's kind of the target for her therapy, at least to start, is to try to create balance in kind of an imbalanced body right now. So she's got a combination of tightness kind of in the front of her body and weakness in the back of her body. So being able to kind of reposition her and be able to work on things like just general posture, strengthening, stretching, really, really important again here, just as much as it was in the other case. And like I said earlier, it's a matter of what is it that's impacting her function. So what are the impairments that are really impacting her ability to do the things that she wants to be able to do? And oftentimes these things are things that are chronic conditions. So one person had put in the chat that, they've been going to OT and PT for over a year and they still don't have full range of motion. To me, the most important thing is, does the range of motion that you have available to you now, does that continue to limit your participation in things that you want to be able to participate in? Because you may still have decrease in the range of motion because of everything that's been going on, but at least if we can maintain that to maximize your ability to participate in the things you want to do, that's really the main goal here for rehab. So another thing that would be beneficial for Jackie here is to work on sleep. Positioning often is difficult for someone to participate in sleep and get appropriate sleep because of pain, fatigue, migraines, kind of blood pressure regulation, things like that. And also finding ways that she can kind of compensate for some of those blood pressure issues. So often someone like this might, when they go to sit up, get really, really dizzy, or when they go to stand or participate in activity, get really dizzy. So trying to build in ways that she can improve that with the way that she does certain tasks throughout the day. So once again, kind of restructuring what her day looks like to maximize her potential. And then pain management and education. So being able to figure out what would work better for her in terms of kind of organizing the activities that she does, and then educating on other ways that she can minimize her pain and support her quality of life. And there's this concept in chronic conditions in the occupational therapy sort of world that's called lifestyle redesign. So it's essentially restructuring your life around how to kind of maximize your potential and be able to use the strength that you have and the energy that you have effectively throughout the day. So something like that would be really helpful for Jackie with the multiple issues kind of going on in the chronic landscape of this disability. Next slide. So when might you see cancer rehab or have the opportunity for cancer rehab? And really the answer to that is throughout the entire continuum of cancer. So sometimes you might have a referral to a cancer rehab physician or specialist really early on. Often we really don't see it until you've started to have some significant physical impairments. Then you might get that referral to a physiatrist or a physical rehabilitation doctor. And even with that, often you need to be your own advocate to know that there's impairments enough that are affecting you that you could benefit from PT, OT, speech, and a PM&R doctor, a physical medicine and rehabilitation doctor. And you may have the opportunity to come in contact with an OT, PT, or speech therapist in the hospital right after surgery. You may get an evaluation from them. They may say how you're doing with walking, with mobility, with range of motion. That might be your first kind of glimpse of what that would look like. And then if you have a significant decline or you have some sort of severe surgery that results in the ability to not be able to go straight home from the acute care hospital, then you might end up going to inpatient rehab. So that's what I specialize in, is working in an inpatient rehab facility. So often that's someone who's not able to go straight home after either surgery or some sort of significant decline. And we kind of balance the ability to transition home between increasing family support and education and increasing independence at the same time. And then not all inpatient rehab facilities are created equal, and the same thing goes for outpatient facilities. So it is important to know what facilities are out there that have cancer rehabilitation specialists. So it may just be as easy as looking on the website to see if they specialize in cancer rehab or if they've had experience with individuals with cancer in the past. You also might see PTOT and speech in the home care setting, and it could be really beneficial, especially when you're first transitioning home from the hospital. But the ideal environment for kind of management of the continuum of cancer rehab is really in the outpatient setting. And Dr. Stubblefield and Elena will probably talk a lot more about that. Next slide.
So from a rehab standpoint, one model that we often use when we think about a patient is what we call the ICF, or the International Classification of Function, Disability, and Health. This is used by all different types of providers, and it allows us to look at the patient from multiple angles. So what are the health conditions? Oftentimes in this situation, we're talking about a cancer diagnosis or side effects from your treatment. We look at how it impacts your function and your body structures. So what are you having balance difficulties, fatigue, range of motion would fall into those areas. We link those back to how do they impact your activities. So things you're able to do every day, such as reaching up into cabinets, putting on a shirt, helping your kid. And then how does that link into your participation? So how you interact with your family, your friends, and your community. So while that reaching into a cabinet may be a difficult thing for a personal task, that could also really impact your ability to care for your family if you're not able to get pots and pans down or food out of the cabinet and translates into your function. Additionally, we take into consideration your environmental and your personal factors. So things that are important to you and that's in beliefs you have internally, your age, your environment, being your community, your house, your home, and how those all work together. So we take this large landscape through the ICF model to really understand who you are and to tailor our rehab approach to you individually. So no two rehab approaches should look the exact same because we all have these different factors. Some people have a lot of side effects of their treatment, others have very little, but maybe their personal and their environmental situations are difficult compared to other people. So it's important when you're working with a provider that they take all the aspects of you into consideration to plan the best treatment course for you. Next slide. Well, we're going to kind of go through the next few slides. We're going to talk about the different areas that physical therapy, occupational therapy, and speech and language pathologists can help. We all do work as a team, but we do have slightly different areas we focus and specialize. From the physical therapy standpoint, we really focus on how we can maximize your function and improve your quality of life. Oftentimes that has to relate to your mobility, help reduce your falls, increase your strength, your endurance, your balance, and your flexibility, help you manage chronic pain, manage changes in your sensations such as CIPN or chemotherapy-induced peripheral neuropathy. We look at how you manage your fatigue, lymphedema management, and we really support returning you back to your ADLs, your activities of daily living, as well as your work and your recreation. Next slide.
So in occupational therapy, the focus is really getting back to being able to participate in occupation, right? And here, occupation means how you occupy your time, how you occupy your time, or how you want to occupy your time. Not necessarily work or employment, but often employment does fall within that occupation umbrella. And really looking back on being able to increase your participation in life roles. So being a mother, being a worker, being a wife, being a husband, anything like that. So OT kind of finds the balance between ways to support restoration of function, so strengthening, stretching, range of motion, management of fatigue, lymphedema management, and cognitive rehabilitation, but also kind of pulls in more compensatory techniques. So different equipment suggestions, medical equipment suggestions. It might be as simple as use of a shower chair while bathing, or using a long-handled sponge while bathing. Or it could be as complex as figuring out a way to get a rental stair lift to manage the external stairs in and out of your home, because stairs are limiting your ability to participate in the community. So OTs often go through the whole landscape of what goals are most important to you and what life roles are most important to get back to, and then focus kind of more in that specific area. Next slide. And then a speech language pathologist,
You're good.
Speech language pathologist might also look at similar things from a cognitive perspective, but they'll also look pretty deep into speech and swallowing. So you may get a referral, and you may have already had a referral for speech and language pathologist to see you, specifically if you've had something like head and neck cancer. But it's really not just head and neck cancer that would benefit from a speech language pathologist. So it might be anyone who has difficulty with speech or swallowing related to chemo, related to radiation, related to any other cancers, particularly thyroid cancer, lung cancer, management of chronic pain management specific to kind of the throat and speech and the head and neck. And then they also do lymphedema management as well, and can focus more on cognitive rehabilitation. Next slide.
So we're going to do a little practice here to understand some of the questions we look at from a rehab standpoint. So if you don't have a piece of paper, go ahead and grab a piece of paper or somewhere you're able to just jot down some quick notes for you. And you're going to start to look at these questions, and I'll read them out. When we look at them, you're going to give yourself a score from 5 to 1. 5 meaning you feel excellent with it. 4, you feel very good. 3, you feel good about it. 2, fair. Or 1 if you feel poor about the particular question. So go ahead and take that piece of paper. And if you want, feel free to number it down. But really, we're just going to start to look at the different areas of where you give yourself scores. The first question is, in general, how would you say your health is? And I know we can go into these questions, but go what comes to first to your mind. Go ahead and give yourself that score. Number 2, in general, how would you say your quality of life is? Again, what comes to your first thought? Go ahead and write that down. How would you say your quality of life is? Number 3, in general, how would you rate your physical health? How would you rate your physical health? Number 4, in general, how would you rate your mental health, including your mood and your ability to think? How would you rate your mental health, including your mood and your ability to think? Number 5, in general, how would you rate your satisfaction with your social activities and relationships? How would you rate your satisfaction with your social activities and relationships? Number 6, in general, please rate how well you carry out your usual social activities and roles. This includes activities at home, at work, and in your community, and responsibilities as a parent, child, spouse, employee, friend, or any other roles. How would you rate your ability to carry out your social activities and roles? Okay. Next slide. Number 7 is a little bit of a different answers we're looking for here. We're looking to your 1 through 5 again, but number 5 is complete, mostly is number 4, moderate is number 3, a little is number 2, and 1 is not at all. So for number 7, you're going to say, to what extent is your ability to carry out your everyday physical activities, such as walking, climbing stairs, carrying groceries, and moving a chair?
Slide 5.
So carrying out your normal everyday physical activities. Number 8, in the past 7 days, how often have you been bothered by emotional problems, such as feeling anxious, depressed, or irritable? Give yourself a 5 if you said never, 4 for rarely, 3 for sometimes, 2 often, and 1 always. So how have you been bothered with emotional problems, such as feeling anxious, depressed, or irritable? Number 9, in the past 7 days, how would you rate your fatigue on average? 5, you give a none, 4, mild, 3, moderate, 2 severe, 1 very severe. And then on a pain scale from 0, no pain, to 10, the worst imaginable pain, how would you rate your pain over the last 7 days on average? Your average pain over the last 7 days from a 0 to 10. Okay, next slide. Couple more, and I know these are probably getting kind of routine now. So we're going to go back to some answers around without having any difficulty will be a number 5. Number 4 is with a little difficulty. 3 with some difficulty. 2 with very much difficulty. Or 1 you're unable to do. The first question on the series is, are you able to do your chores, such as vacuuming and yard work? Are you able to go up and down the stairs at a normal pace? Are you able to go for a walk of at least 15 minutes? Are you able to run errands and shop? And our last section on here, number 5, you'll give a never, 4, rarely, 3, sometimes, 2, usually, 1, always. I have trouble doing my regular leisure activities with others. I have trouble doing family activities that I want to do. I have trouble doing my usual work, including work at home. I have trouble doing all the activities with my friends that I want to do. So leisure activities, family activities, work, and all the activities that you do with your friends. And then we have one last slide in these series of questions. We'll go to next slide. This one, when we look at this question, many of you may say, I'm not working in an occupation or outside the home right now, and that's okay. Whatever you embody as your work, as what you do on your daily basis, is what you want to think about this question. From a 1 to 10, or sorry, 0 to 10, rate how many points you feel like you are able to do your work. 10 meaning you're able to do all your work to the best of your ability. 0 means you're currently not able to do any of your work. And again, this applies to any of your daily activities, not just occupational or work outside the home. And then rate your ability to do your work in respect to your physical demands. Give yourself a letter A if you're able to do it very well or very good. B for rather good. C, moderately. D, rather poor. E, very poor. Similar question, but rate your ability to do your work in respect to your mental demands for your work. A, very good. B, good. B, rather good. C, moderate. D, rather good. Or E, very poor. And then our final question for this whole situation right here is, how many times have you fallen in the last 6 months? How many times have you fallen in the last 6 months? And as you finish that question, I want you to look at your piece of paper. And if you have ranked yourself a 3 or less on those first 15 questions, that means there's potentially an area in which rehab can help you. So if you have ranked yourself a 3 or less, those are areas in which rehab could potentially be beneficial. On these last questions here, if you gave yourself below a 7 or a B on either the mental or physical components, or if you have a number anywhere above a 0 for falls, those are areas in which rehab can help. Which of us professionals is the most accurate appropriate for you? I know sometimes a difficult question. And that's where we lean into where you answer different questions of which one of us on the team is going to be most beneficial, or all of us. We often work together in interdisciplinary settings where you may see PT and OT and SLP, depending on what particular impairments or situations you have. So I know some of these can be difficult. These questionnaires were not actually designed for the cancer population alone, but they're designed to understand an individual's quality of life, no matter what's going on. We recognize many people have things going on after a cancer diagnosis that may make these impairments more present or more difficult to perform to their daily tasks. So do recognize we do have to often take encompass what all medical conditions you may have going on, or those personal factors, things important related to you, or maybe your environment. Many times other people have other family members ill or sick at times, and that can also impact your health as well. Okay. We'll go to the next slide. I forgot we had an official slide, so we'll go to the next one. So we do come from Select Medical, as Dr. Stubblefield said. Vital Cancer Rehab is our outpatient program through Select Medical that we have. Currently, we're serving over 21 major markets, and we're adding new markets all the time. So you may not see your particular home location on this map, but there are other rehab professionals as well. So you do want to look for someone who is a cancer rehab specialist. When we think about this map, ways you can reach out to us is if you look at our next slide for us, is our website, revitalcancerrehab.com. Will allow you to get an understanding where our different locations are. Charlene, unfortunately, we are not in Hawaii right now, but there are other cancer rehab specialists I know in Hawaii. So what I would recommend is touching in with your oncologist or also searching for cancer rehab, and you might find that local support as well. Any other questions?
Yeah, that was terrific. So I've been looking at some of the questions coming through in the chat. We still have 7 minutes. I talked New York fast to try to get through to make sure we had a little bit of time for everybody. So general questions as opposed to specific, like to you questions are always appreciated, but please spit them out there. We're happy to help. So one of the things that we discussed that I just want to kind of double down on are the primary types of cancer rehabilitation clinicians. So I'm a cancer rehab doctor. I kind of joke, people call me a physiatrist, but that sounds like psychiatrist. So I call myself cancer rehab doc to minimize confusion. And my job is to figure out why you're having these impairments, identify all of them, and make sure I send you off to the right person. That being said, there's not a ton of us out there. So physical therapists are really more concerned with strength, gait, posture, stamina, that sort of thing. Occupational therapists like Kira are more concerned with your ability to do activities of daily living, also to some degree your cognition, but they also do strengthening, stamina. They'll do energy conservation techniques and that sort of thing. And speech and language pathology, which we don't have here, does speech and swallowing issues. They help you, they do swallowing tests with physicians, and then they help your ability to swallow and your ability to talk, but they also do cognitive issues. So there is certainly quite a bit of overlap. All right. Yeah, so Susan G, it depends on what you have, but absolutely, you know, I almost always, when I say breast cancer patient, for instance, I don't know what your cancer is, but I'll commonly send them to PT for their shoulder range of motion, OT for their lymphedema management. And if they're having cognitive issues, I may send them to speech language pathology as well. How long will my joint pain after Herceptin treatment? Don't know. Screaming tinnitus, what can I do? Again, you know, it's hard for us to give more than just sort of couch advice for a lot of these things. Are there insurance road bumps? That's a great question. They're all great questions, so we should be aware of. Yeah, so cancer rehab is just rehab, right? So in terms of what your insurance will pay for, if they're going to pay for back pain, they're going to pay for us because we bill, the codes we bill, we depend on are just usual sort of CPT codes that is kind of the medical speak for any impairment. So if you're coming to me with dropped head syndrome, I'm going to put in cervicalgia, neck pain, which has a code with it.
There's a good question about telemedicine. It really depends on you individually of what your care needs are. We do have telemedicine at most of our markets and is available to them. And we know that's been a really big lean in for people who are trying to stay more isolated right now. So it really kind of depends on your individual symptoms and what kind of home setting you have and support, but definitely isn't an option for many patients. a question around having metastatic disease. So as Dr. Stubblefield said, we see anybody at any type of cancer, at any stage of cancer, and throughout the entire cancer continuum. So it does not matter if you've had stage 0 cancer or you have metastatic disease. Rehab is definitely something we work with and help you maximize your function. So making sure we individualize those goals and adjust depending on where you are in your cancer journey. So yeah, metastatic disease is definitely something rehab works with commonly.
Yeah, exactly. We're not intimidated by the fact that patients, have more advanced cancers. And in fact, really kind of no matter where you are on that stage, on that continuum, we almost always have something to offer, even if it's just energy conservation techniques and training you and your family how to transfer safely and get in and out of a car and, getting you the tools you need to do well at home, like, that you may not have thought of. So there's no place in cancer where we don't think we can potentially offer something. Sorry, somebody had asked about a scar. That is just so variable, it depends. But yes, the scar massage can definitely be useful. I should leave that to Elena. She does probably more of those than I do. I don't treat the scars, I send them to be treated.
And 7 months out is still, in our eyes, is not that long. So, can it still help at 7 months? Absolutely. I think working with your therapist, working on understanding where that tissue is definitely not too late per se.
Yeah. And Stuart has a question about COVID. Has it constrained our ability to offer therapy? So I'm in New Jersey. Kira's in New Jersey. Elena's in Colorado, lucky. So the answer is initially at the pandemic, we had a lot of trouble. We switched immediately to doing virtual visits as the kind of tide went out, so we couldn't see people in the clinic because New Jersey has been pretty well controlled. It's come back in, and the vast majority of our patients are now in-person, mask distanced, vaccinated, and our issues have been relatively low here, fortunately. So when you're saying fatty liver fatigue versus cancer fatigue, again, that's something that you need more of an assessment than any of us can really answer over a Zoom call to really know all the issues there.
I think one thing when we think about fatigue, it's usually multifactorial. So exactly. It could also be sleep. It could be nutrition. There's a lot of things. It's difficult for us to always say, is it just one component? So that way having that further assessment can be beneficial.
Yeah, and Judith, it looks like, has a great question. Where do pain clinics fit into this? So when I was at Sloan Kettering, we had a pain and palliative care service, an anesthesia pain service, and the rehab service. Guess who was the most busy? By far, manyfold, it was the rehab service once we built it, because most patients' issues are functional. They're even if there's a big component of pain with it. So most rehab doctors are more than qualified to do pain management, including opioid-based management, but we don't always have to. So if you're going to go to most interventional pain physicians, their primary interest is giving you shots, right? If they can do a cervical epidural shot to help you, which may not be what you need. You may need, certain medications targeted to your issue and therapy, right, to get a better outcome. So they fit into this when our traditional things can't help and we have a specific issue that needs a shot. I also do, a tremendous number of shots, just not the cervical epidurals, for instance. I see Megan back on, so ruh-roh.
Yes, if there are any last words for this session that you want to share with the audience before we finally wrap up?
Absolutely. If you're suffering from an issue, I hope you take one thing away from this, is that while we can't cure everything, there's help. So I would make sure that you try to find clinicians that can, have the biggest chance of helping you. And it's often the physical and occupational therapy and physicians, who are knowledgeable about the issues facing cancer survivors.
Well, thank you so much, everyone, and bravo to our amazing panelists. We thank you for your time and the information. So when this Zoom ends, please go back to GVCC21.com, log in, and from the homepage, you will find a button that says Happening Now. This will take you to the next live session, and we're happy to See you there. Bye, everyone.